Welcome to the Paradox PT podcast, where we discuss all things physical therapy, rehabilitation, and clinical practice. I'm your host, Leo Falzon. Today, I'm speaking with my colleague and friend, Adrian Flis, about patellofemoral pain. Adrian is a resident physiotherapist who graduated from the University of Waterloo with a BSc in kinesiology in 2018, and from the University of Toronto with an MSc in physical therapy in 2020. He currently provides care out of two private practice orthopedic clinics in the GTA, Shedden Physiotherapy and Sports Clinic in Oakville, and Umana Health in Etobicoke. My favorite thing about Adrian is that he brings a sense of humility and an open mind to every topic. He's extraordinarily smart and skeptical, but he's equally humble and curious, which makes him a great conversation partner when it comes to anything rehab related. Today we explore the ins and outs of patellofemoral pain, a super prevalent condition that we've both had our struggles with treating in clinic. We try to be as granular and specific as possible with respect to our clinical reasoning and decision-making frameworks around this condition, so that whether you're a new grad or a student, hopefully there's something in this conversation that can help you level up your patient care. Without any further ado, here is my conversation with Adrian Flis about all things patellofemoral pain. Adrian Flis, thanks for coming on the podcast. I thought we'd start off by, maybe I would just ask you what you hope to get out of this conversation. What do you want to have accomplished by the time we're done talking about patellofemoral pain?
Yeah, first podcast. This is a little bit nerve-wracking, but let's try not to act like experts. So what I want to get out of this conversation is just a clear idea of how to treat this subgroup of people. In my experience, and the reason why we thought to have this podcast is because I've had difficulty in the last year treating this subset population. And I think we kind of mentioned that you did it as well. So within the week of the idea sparking up that we'd have this conversation today, I've learned a lot, which is great. It shows you, like how much you can learn within a time frame if you really put your mind to it. But I think talking about it and kind of having a nice framework for treating this population might make it a little bit less scary. Because right now, the way that I'm thinking about patellofemoral pain is when a patient comes into me and I'm seeing those signs of patellofemoral pain coming in, there's a little bit of me that thinks that, okay, how are we actually going to get this patient better? The research doesn't really favor a good prognosis.
Mm-hmm. And I've definitely felt the same way over the last year. They're tricky and they're not like these quick fix patients. And hopefully today, I think for me, success would be diving into the details a little bit, because there's a lot of materials out there online which summarize the research and go into what the RCTs say and what the prospective data say, and we will touch on a lot of that, but I think kind of getting into what it actually looks like in practice with patients is the gap that I want to bridge here, and just have a better like a resource we can look back on to say, okay, here are some foundational pieces of knowledge around patellofemoral pain that I can hang my hat on. So,
yeah, and hopefully the knowledge that we talk about today is grounded well enough that there's not going to be major changes within it in the next 20 years, for example. Whereas if you kind of focus on the tiny details of what's established in the research, that stuff can change, week by week, month by month. So frameworks are better than anything, I would say, for any sort of condition. I think it's a good thought experiment just to do this for any area that you find a little bit of trouble with.
Yeah, totally. So let's dive right in. I thought we would start off by defining patellofemoral pain. So for anybody who's not aware, what is patellofemoral pain?
So patellofemoral pain, the big thing that a lot of these studies try to establish is that it's a diagnosis of exclusion. So make sure that you're not just diagnosing patellofemoral pain with just the subjective criteria right there. So overall, it's kneecap pain. Like it's a fancy Latin term for telling us that there's some pain coming around the knee joint.
Mm-hmm. And okay, so you said it's a diagnosis of exclusion. What are maybe like some of the major conditions that you'd want to be ruling out? Because I think it's a key point with a lot of our diagnoses, like non-specific low back pain or rotator cuff related shoulder pain. we're better at ruling things out than we are at ruling things in. So we're good at saying it's not X, Y, and Z, so therefore it's likely, this.
Yeah.
So what are the things with anterior knee pain that could masquerade as patellofemoral pain or could that you're trying to exclude?
So the classics, that you learn from PT school is just making sure that everything is intact within like the ligamentous structure of the knee. So thinking about those special tests that, you have to memorize from day one, MCL, LCL, ACL, meniscus, those are the big ones, right? And then once you've kind of gone down that pathway of you want to look down. You'd also want to look at like patellar tendinopathy. Tendinopathy as well. Like the quads would be a good example. And then like within those special populations or like those weird cases, that you'll see maybe like once every 6 months, like the Osgood-Schlatters, any like loose bodies within the knee, the scary ones like osteosarcomas. Obviously some of these are a little bit easier to rule in or rule out just based on the conversation that you have with that patient.
Mm-hmm.
So it's easy for your mind to think, oh, I know exactly what this is. But because of that criteria of diagnosis of exclusion, we should try to do a good job making sure that we're not treating the wrong thing. Because this is the thing that we've been seeing, right? Like some of the people that don't get better with patellofemoral pain might not have patellofemoral pain, right?
Yeah, and thus might not respond well to interventions that are tailored to patellofemoral pain.
Yeah.
So I guess for me, just to kind of build on that a little bit, some of the subjective points that are key to clarify in your history are if it was a traumatic injury, you're likely going down more the path of your ligamentous structures or meniscal structures.
Yeah.
Very unlikely to have like a one traumatic incident that's patellofemoral pain, even though that I guess can happen in the odd case. And yeah, with tendinopathy, maybe it's worth briefly just describing like a few factors. And for anybody who wants to dive deeper into this, Jake Tura has a couple great episodes with Jill Cook, who's like world-leading patellar tendinopathy researcher on the Jacked Athlete podcast, where she talks about really how to differentiate between the two. But the few points that I would hang my hat on are, one, with patellofemoral pain, it's often poorly localized and broad. It's a diffuse, so they'll kind of point, they'll put their hand on their knee and say it hurts here, as opposed to with patellar tendinopathy, they will point to their patellar tendon and they will say it hurts there.
Yeah, so kind of that pinpoint pattern versus more of a diffuse localized. That's a big one for me.
Yeah, and as they load that tendon, the pain stays there. Whereas in PFP, often the pain will kind of travel and spread. And
with tendinopathy, right, we know that those slow, heavy, resisted loads might actually feel better. Give it a little bit of time, spend some, really get a sense of, does this pain change? Does it get worse? What's the pattern that I'm seeing in front of me?
Yeah, 100%. And so I had patellar tendinopathy when I was like 15, 16, playing soccer. And I would say one of the interesting things about that versus PFP is it has a clear warm-up effect. So it would hurt getting out of bed. It would hurt when at first few steps kind of on the soccer field. But then once I was warmed up, I could manage. And then it would hurt like crazy after and the next day. Whereas PFP, the more you load the patellofemoral joint, the more it's going to hurt, in my experience with patients.
Yeah, and I think that's the tricky part with PFP, because a pattern of pain like that will really scare people into exercise, right? So that active population that used to, love those weekend runs might not be able to do that anymore.
Yeah, totally. Just to close the loop on maybe diagnosis, and we're not being super thorough, but it's good to at least, do a bit. What are the key activities that you would see as aggravating for people with patellofemoral pain?
So I try to remember the 4, but overall it's some sort of deep knee flexion, for example, when it's loaded. So going upstairs, going downstairs, those are 2 easy ones to remember. Running is a good one. And then also any deep sort of squatting. But it's interesting with this population because that seems like an active kind of pain pattern, but some people just have pain with sitting.
Yeah.
So it's a tricky one.
Have you delved into the research at all about what, like they call that the cinema sign, pain with prolonged sitting, as to why that occurs?
Not really. I would say, just going back to the Jacked Athlete podcast that we were talking about, some good understanding of why it might happen with a tendinopathy. And with tendinopathy, I guess the idea is fluid within the knee, right? Just allowing that joint to be at rest and letting that fluid or whatever sort of material is within that knee kind of sit in a spot, and then a sudden movement, like getting out of the chair, might put some weird kind of strains into that tendon.
Right.
Not so sure about patellofemoral pain.
Yeah. So the only thing that I've heard about it, Claire Robertson, who's a physio in the UK who specializes in PFP, she hypothesizes that the subset of PFP patients who have the cinema sign have tight quads, which I'm not sure what to make of that, but she was saying that something about the architecture, the musculature in the front of the leg, if they're in that kind of short seated position where the patella is being somehow pulled into a position where there's pressure on the sensitive structures, maybe that could account for it. But I don't think we understand it. There's probably a lot of dynamics going on.
And I guess just an interesting tangent, right? My understanding of tightness can sometimes go to that understanding of weakness.
Yeah.
Right. As we discuss sometimes. And
totally.
I wonder if that same subset of population, like, it would be a good idea to, if you have a cinema sign, what does that quad strength look like?
Yeah, totally. Yeah, which is what we'll get into in terms of assessing people. Okay, one last thing about PFP before we move forward into risk factors, assessment, and treatment. What do we know about the pain source? Because, if you kind of bring it on to something like non-specific low back pain, the whole idea there is that we don't know from a research perspective. We don't have the clinical set of tests to assess what the structures are that are causing the nociception peripherally. So with PFP, there's some hypotheses. Maybe just give us a summary of what those are. And
it's kind of funny. There's a couple camps, right? There's some people that would want to call this issue anterior knee pain, right? Super non-specific,
right?
But some of the leaders are shifting away from that and trying to, it's a good idea to differentiate between all the other stuff that we've been talking about, right? So anterior knee pain, like what else could be causing that pain, right? So I think the major argument for where the pain might be coming from, even though it's a little bit murky, is kind of that subchondral bone, which is highly innervated. But what's your take on it?
I think we know what isn't causing the pain, which is cartilage, because the cartilage doesn't have any free nerve endings. Yeah. So it can't be that. The most reasonable theory is that it's the bone that's right under the cartilage, or I think some people have postulated that it could be the synovium, like the tissue that kind of surrounds the joint.
Even people talk about the fat pad as well, right? There can be a little bit of there's a lot behind that knee, right? It's not as simple as bone over bone.
Yeah, although I think I've seen one fat pad patient, and it had a completely different presentation to most patellar femoral pain syndromes, like pain with extension. Where you're compressing that fat pad. And so it seems to me like they're two distinct things.
But I would say one of the aspects that people are looking at with thinking about where this pain might be coming from is, zooming out of that biomedical paradigm where you're thinking about pure structure, right? So the one thing that we kind of talked about off air is those psychosomatic factors, right? Everything else that makes pain so complex, right? So kind of touching on the fat pad discussion, hard to say. I'm just kind of thinking, what if it's a little bit of everything, right? Yeah. Like, could there be situations where it's just more than one structure, right? Like, or is it hard to say?
Oh, for sure. And I mean, this is the thing that it's hard from our perspective to really have a really strong opinion on this. Because Jill Cook, she was very, very adamant that you can't have patellar tendinopathy and patellofemoral pain syndrome at the same time, whereas Claire Robertson, who also has treated like 10,000 patellar PFP patients, says that she's seen it a bunch. And then Jill Cook also said that she doesn't even see fat pad patients. She's like, I don't really think it's a thing. And then,
yeah, it's
Claire,
murky. So it's quite murky, right?
I think it doesn't, at the end of the day, it's really getting into the minutiae of it.
At the end of the day, is it going to change what we do?
Yeah, well, sometimes, right? And that's where it's important to try to figure out when it is and when it isn't.
But going into the kind of the sometimes scenarios, right? Like, as long as you've ruled out those big factors, right? Like, anything else that needs more medical attention, as long as we're keeping track, we're constantly reassessing each time the patient comes in, it might not be that worth it to focus so much on, is it subchondral bone?
Yeah.
Is it this,
sure.
Is it that?
So yeah, for me it's not like, is it the synovium or the subchondral bone? For me it's more, am I missing like a meniscal issue? Or like an osteochondral defect that's going to break off and there's going to be a loose body floating around which needs surgical intervention. I've seen 2 of those.
Yeah.
Where you could look at them and just say, well, it's painful knee, it hurts with flexion, gonna just give them strengthening exercises.
Totally.
But they needed a consult with a surgeon. So
yeah, no, totally.
Yeah.
And I think from that podcast that we were listening to, like, really great resource, the Bradley Neal podcast. Big takeaway from that is those synovitis patients, right? Those patients with loose bodies of cartilage that break away, can cause this kind of inflammatory reaction. That's not really on my radar.
No.
I don't think I've ever really seen one of those, but it's a good idea to keep an eye out for what could come into the clinic.
Yeah.
So again, we're not treating the wrong thing for weeks on weeks on end.
For sure. Yeah. No, I think that pretty much closes a loop on tissue source of pain. So I thought the next thing that we could discuss is prognosis, because this is something that I didn't realize how bad the situation was.
Yeah, and this is what caused me to have this discussion in the first place, right? It can be a little bit depressing.
So what do we know about the prognosis and the outcomes of people that are diagnosed with patellofemoral pain?
So looking at the stats, looking at our little notes that we brought in, 90% of patients with patellofemoral pain can still have symptoms 4 years after diagnosis. How does that make you feel?
All kinds of ways.
Yeah.
And yeah, so there's a few different prognostic stats, but one meta-analysis that Brad Neal cited showed that 60% of people with PFP still report significant pain 5 to 8 years post-diagnosis.
So I guess it does depend on the studies that you do look at.
But I think that's, yeah, it does.
Yeah.
It does. So then I thought it'd be worth briefly touching on the hypotheses around why it has such a bad prognosis. Because the question is, what feeds into that stat, right? And so maybe the first point, which was Rich Willie's point, was that he thinks it's a consequence of undertreatment, which is that we as physios don't actually carry out a long and thorough enough strengthening protocol and management program with these people. They fall off after a month and then they have a recurrence, when they go back to their sport. And so that was his hypothesis, but so what's your thought on that? Maybe
just touching on that, the one big takeaway on that aspect of things is this is a tricky diagnosis, right? Our natural history is not going to do a great job in treating this patient. So throwing all our fancy tools and just hoping for the best most of the time doesn't work, right? So it seems like, the current guidelines for the way to treat this is through exercise. But if we're looking at exercise from like a strength change component, that's 6 to 12 weeks minimum, right?
Yeah.
So how long are we seeing patients, right? So with some of these patients, they'll fall off in 4 weeks because they're discouraged. Especially considering those first 6 months that I was working, I didn't know how to treat these, right? We didn't really get a good understanding of what the best protocols for these patients is. And it can be a little bit of a doozy. So if you don't have that framework and have that, establish, what the expectations are from the get-go, patients are going to ask, I've been coming to physio for 4 weeks. I've spent a bunch of money on this and I'm not seeing any changes. So it can be tricky to try to convince that patient, 4 weeks after it, oh, it's just a strength thing. It's just a strength thing. But if you make if you make that really clear at the beginning of like what to expect over the next 6 months, that might drive up that stat a little bit better.
Yeah, no, I totally agree. And I think a really nice way to think about patient satisfaction is that it is their current state minus their expectations.
Yeah.
Do you know what I mean?
Yeah,
so
true.
if you set their expectations way too high that you're going to get them out of pain within 2 weeks,
yeah.
And then honestly, that could be a consequence of you being ignorant about the prognosis of PFP.
Totally. Yeah.
And then they're not, and then you're surprised that they're not better.
Yeah.
Because you've only treated like 2 of these.
Yeah, and then
maybe
they
were misdiagnosed and you didn't treat them properly.
Totally.
And they got better. And so, and then they don't get where they want to get, and then they fall off because you lose that trust. But yeah, like setting expectations, I would say if I could give myself, a piece of advice starting out, understand what the prognosis is, and then you can build small wins within that treatment plan where it's like, okay, I don't really care that much about your pain in the first 4 weeks here. Totally. This is a chronic thing you've had for a year. Like all I want is for us to hit these movement targets or these strength targets, which we're going to measure, objectively. And then the patient's bought in, and it's like, okay, they didn't think that they were going to be completely magically cured within 2 weeks. So
you'd be surprised how well people take, these depressing stats. If, for example, you might not get better in 6 months, right? And even after 6 months, you might still have recurring flare-ups, right? But people take that well. If you're honest with them, it's not a scary subject to have, right? Because I think when I came out of school, I thought I'd be this fixer of everything, right?
Yeah.
And it sucks not being able to get someone better within that kind of crisis mode. They come in with knee pain and they're training for a race, for example, and you might not be able to get back in that first month, right? But let's think on the big picture here.
Yeah. And I mean, I guess that's the thing, right? Sometimes it is damage control with patients where they have maybe that's where there is some merit in just doing things to make them feel better and simply symptom modifying.
Yeah.
If they have a race, or like I think in sports physio, a lot of times you're just getting people through it, right?
Yeah, like, can't get someone stronger in an hour before a game, right?
Yeah, whereas like in an outpatient setting where it's more your general population, runners and whatever, who don't have like the need to like hit a certain race, you can kind of step back and say, like, let's reset some goals and we'll build you up from the ground.
Let's think longevity.
Ground zero. I think that's critical. And I totally agree with you that we often, when we come out of school, think that we should be able to fix everything. But it's almost freeing in a sense when you realize that we only have the power to influence certain things. And
totally.
It's like the human body isn't like we're not magicians.
No,
like there's certain things that we do really well, but we can't fix everybody. And when you come to terms with that, I think the client really it's comforting because they can tell you're being honest, and you're just like, hey, this is the prognosis. I think we got a good shot if we put in work for like 3-4 months of seeing good progress. What do you think? Do you want to have a go?
Totally.
And it's like
totally, and you need to buy them in, right? Because it's not. When we think of ourselves as magicians, all of the pressure is on us, right? But we need that patient to be bought in. We need that patient to be doing the work, right? It's a mutual agreement.
Yeah, 100%. And, as a bit of a tangent, this is where I feel like in my setting at Umana Health, because we have a gym environment, I've had decent results with a couple of patients with PFP because I can say, like, I'm going to see you twice a week. And they're down to do that and do the strength training there. And we can really properly progress their loading. Whereas I feel like sometimes in the past, if you just put somebody on a home program, they might not have the tools at home to adequately load themselves.
Yeah.
Or like maybe the knowledge on how to progress or regress. And so
and I think like we're gonna dive into this at the end of the podcast, but those specific exercise progressions and even like the tools of like putting more pressure into the knee versus the hip, those little tiny differences that can make or break that person's lunge, for example, right?
100%.
It can be tricky, like doing everything at home and relying on yourself, right?
Yeah.
And trying to fit everything in within a confined treatment time.
Yeah, and I think sometimes like there's obviously this big movement towards self-management, which is great, but I think being experts about movement and coaching exercise should be one of the things that we're good at.
Totally.
And I don't feel as bad as I did when I started telling somebody that it's going to benefit them to come in twice a week.
Totally, yeah. And like self-management comes from a good foundation, and you need to build that foundation early on, right?
Yeah. Like how often have you had somebody just fall off because you kind of sent them away and said, "Oh, I'll see you in a week," and then they don't see changes because
they've had a busy week, right?
Yeah.
Exams hit, stressful week at work. I didn't do any of the exercises. Okay, so we're exactly where we were a week ago, right?
Yeah.
We're thinking big picture.
Whereas if we had seen them twice, they might have bought in, they might have like prioritized that. So it's a really fascinating thing.
It is. And I think this is the reason why we're having this discussion is because these details matter in this population.
Yes.
And some other injuries that we're treating, it doesn't matter as much. It's not that it doesn't matter, but it doesn't matter as much.
And something like a mechanical low back pain that comes in. That's one where they're really good self-limiting prognosis.
Totally.
They don't really even need to see you. Like maybe they need to see, like in a sense that they can become chronic if they don't get good advice early on or something like that. But with PFP, they don't get better on their own. It's not something, like as Rich really said, it's not something you just grow out of.
Yeah.
Like you need treatment. And so this is awesome because so many physios are so nihilistic these days. Like, oh, we have nothing to offer people that's of value, and oh, it's all just natural history anyways. But this is a condition where what we do matters. Definitely. Which is awesome, you know? Like,
it is awesome, yeah. And I think my mindset has changed in the last week knowing that. Yeah.
Yeah.
So to completely shift the discussion and shift what we were just talking about, Bradley Neal on a podcast that we were listening to, also a really good resource in this field, says that the patients that are going in after their second, third, fourth, fifth encounter with a physiotherapist, those gold standard, we only treat patellofemoral pain patients in clinics, they don't get better sometimes.
Yeah.
So it's tricky, right? It's hard to know that, even the gold standard of care doesn't always get rid of pain.
Yeah.
Right? So there's both sides of the end to it, but I think we gotta shift towards more of the middle and in the middle being, providing somewhat of a change, because there's a lot of patients that I've seen with this issue, like we talked about, that just fall off, and there's no change within the time that you see physio.
Yeah, and I think that to a large degree comes down to excellent communication skills, even more than having a good understanding of the research. Like you have to build trust, and you have to build that therapeutic alliance. So somebody that is consistent, like. And people feel so guilty about holding somebody to a treatment plan. And it's something that I did at first as well. Like, you're like, oh, well, this person's only got X amount of dollars to spend on physio. It's like, well, yeah, but if you don't intervene properly, they might have a significant amount of disability for longer than they need to.
Yeah, and that's going to cause X amount of dollars as well, right?
Yeah, I think we undervalue what we do. And especially as new grads, maybe rightfully, because you don't really have much experience.
Yeah, what's our value?
Well, no, it's I think, and that's I often talk to people about imposter syndrome.
Totally.
And I think the only way to get over imposter syndrome is to get better at what you do. There's no hacks. You need to actually become somebody who identifies with the value you can provide by getting better at doing that.
Yeah.
So that's it.
Yeah, you got to get confident, right? And you got to know your self-worth.
Yeah. Okay, so kind of steering us back towards the specifics of PFP, I thought it'd be worth just briefly touching on some of the risk factors and some of the data around what predicts who will go on to develop PFP.
Yeah.
Maybe I'll start off with strength.
Yeah.
Just a couple of the studies. I found it fascinating looking into this literature. When you look at military recruits, they've shown that people who had weaker quads were more likely to go on to develop PFP.
Yep.
But that's just in military recruits. So that data hasn't been replicated in like adolescent populations.
Mm-hmm.
And when you look at adolescent populations, a couple of things come out of the data. First, prospectively, people with stronger hip abductors
Mm-hmm.
are more likely to develop PFP. So maybe I'll let you kind of expand on why that might be the case, because that's very counterintuitive. A lot of times physios think, okay, PFP, you're going to have weak abductors. That's like the classic glute med's weak. That's, causing your knee pain. So tell us kind of why that might be a predictive factor.
So just going back to the military recruits, because I think these two areas are what we found to be the bigger risk factors, right? There's a lot of risk factors that people have talked about, and it's in the literature, but it's murky. It's there's not the best findings on it, right? So with the military recruit examples, kind of going with the with what you were talking about, strength, right? Like, okay, so weak quads predict PFP. But no, in a military population, you got to know the details in a way, right? So in a military population, no matter how strong you are, you have the same amount of load on your back, right? When you're doing a lot of the drills and a lot of the tasks. So it makes sense to be stronger, as strong as you can be, so you can last longer within that training camp. For example, if you've never done anything for your quads, there's a good chance that you're going to develop a lot of these other issues, right? So it's hard to extrapolate that to a general population in a sense. Where, for example, some people do have strong quads in a way, and they still have PFP, right?
Yeah.
So always knowing the details is kind of like the big factor that I learned about when we were talking about these risk areas. And then going back to the original question that you had, we had this whole discussion for like a good hour or so figuring out why the heck people, like adolescents with stronger hip abductors might predispose themselves to PFP. And I think the simplest way to think about it is those individuals with stronger hip abductors might just have a higher activity level, right? So they're at a younger age, but they're involved in more sport. So maybe it's that their higher activity levels, thinking about those bigger picture values of, rest and their overall training load is what might be causing some of these issues, as opposed to the valgus and all that stuff that we were talking about, right?
Yeah. No, and I think that's it's worthwhile kind of unpacking it a little bit, because you often see one risk factor in a study, and you assume that it's a link from A to B.
Yeah.
But often A is a proxy for C, which then predicts B. Mm-hmm. So it's like, like you said, maybe people with stronger hips, maybe that's just a proxy variable which reflects their greater activity levels, which could predispose them to PFP. The other hypothesis, which is just worth thinking about, is under the old biomechanical paradigm of valgus being knee valgus being a predictor of PFP and hip adduction being a predictor of PFP. It has been hypothesized that the hip abductors would be stronger because they've had to manage that valgus force. There's a really big moment arm on the hip abductors when you're in adduction, right? Like when you lengthen out a muscle, the hip abductors have to eccentrically control that contraction. So if we're postulating that valgus is related, then maybe the hip abductor strength is, a function of that. So that was the other idea that I read in a discussion portion of a paper. But then the data on valgus isn't conclusive, right? No. So they've shown that I think it was Brad Neal's work actually. He showed that prospectively hip adduction was a predictor of onset of PFP in females, but not in males. But it was like, it's not a really profound association.
Yeah, and it probably depends on the person.
Yes.
Right? So maybe there's these bigger risk factors that encompass a larger population, and then there's these smaller risk factors that you might see. You might still see someone with really poor valgus, and then they jump off of a box and they land in that valgus and it hurts their knees, right? So like, maybe let's try to correct that, but there's some beautiful movers out there, right, that land in all sorts of weird sort of positions and
get pain.
And then it's like, where are we trying to intervene, right? You can get lost in the weeds when you think about the biomotor paradigms.
Yes, you can. And there's one paper that's worth mentioning. The first author was Rebello, and they did an RCT where they compared two groups. One group got hip and knee strengthening. The other group got that, as well as movement retraining, which focused on improving valgus and reducing hip adduction. And both groups got better. Like, both had decreases in pain, but there was no difference in the valgus at the end of it when the kinematics were measured. So that's where somebody like Greg Lehman he's a stickler on, we can't call valgus a fault because people get better even when it doesn't change. You know what I mean? So even if prospectively a few more degrees of hip adduction, not to get in the weeds here, but predicts PFP, if those same people can get out of pain without the hip adduction changing, then what does that tell us? Like, is that a kinematic that needs to be addressed, right? So I think this is probably a good point to contrast some different paradigms for thinking about PFP. Like you mentioned, the biomotor correction, and that paradigm kind of posits that we know what kinematics need to change in order for you to get better. Like, I'm going to address this impairment, which is weak hips, and then you're going to get better, and it's because we address the weak hips. And I think what I've concluded from reading a lot of the literature recently is that we don't know precisely what mediates recovery in people. And there's a lot of things to look at, right? Like, there's overall macro training load, volume, frequency, intensity. There's biomechanics, hip adduction, foot pronation, all this stuff, knee valgus. And then there's life stress, there's sleep, stress levels, nutrition, all of these things. And we can either key in on a kinematic as like we're correcting this biomotor quality, or we can take a more comprehensive look, and this is where the notion of comprehensive capacity comes into play. It's like, if we can't say that I need to fix X biomotor quality in order for you to get better, maybe we cast a wide net instead of casting out one line, right? So I'll let you riff on that.
So Leo and I are super biased because this is the way that we've been thinking about physio ever since we got out of physio school. So I think we're at a weird time in our graduation, right? Because a lot of these models, for example, like the super biomechanical approach where everything is looked at that lens, was kind of fizzling out, or not even fizzling out, but the discussions around it were suggesting what we just mentioned, right? Like looking at a bigger picture. So I think the only thing that I wanted to really mention about this is, for any like new grad listening, it can be complicated. Any of the stuff we're talking about, right? You can think, how do I become an expert in nutrition? How do I become an expert in sleep? How do I provide all these like sound tips and provide an all-encompassing approach? But the way that I like to think about it, and the thing that really that I didn't like about studying like a pure biomotor correction approach, is there seems to be a lot of memorization in that approach, right? You need to know the specific angles of each specific joint and how that plays into a bigger picture and in a moving system. But I think if we just come to the conclusion that the body is complex, then we might be a little bit more easy on ourselves thinking about those bigger factors, right? So you don't have to be an expert to tell someone you should probably be sleeping more than 4 hours a night, and maybe don't have that 10 p.m. coffee. You know, like, you have a lot of these stresses in your life, and it might be seriously aggravating the issue that we're treating here, right? Like, let's think about the big pillars before we dive into the weeds. I think that is probably my biggest takeaway over the last year of being a physio. Yeah,
and then the art of being a physio is figuring out what's a big pillar.
Yeah, totally.
So, like Greg Lehman had this quote in his course where he's like, we can tweak hip adduction by 5 degrees, or we can look at your overall life loads, like sleeping 4 hours a night. Like, which is going to have a bigger impact?
Yeah.
And I think that's something that's worth talking about as we're just moving away from the risk factors. I don't think it's ever one thing. I don't think it's
No,
ever
definitely
like
not.
it's always going to be a constellation of somebody who maybe had an acute spike in loading, maybe there was life stress from the pandemic,
Yeah.
maybe they were sleeping poorly, maybe they have a stressful job, um, and maybe they have weak hip abductors and weak quads, and all these things coalesce, and then there's one straw that breaks the camel's back,
Yeah.
which is nice because it gives us options for treatment, right? It gives us a lot of places to intervene.
Yeah. 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 And I think, like anecdotally, right, the more that I've learned about my body over these years, super biased, right? We come from like a kinesiology approach going into physiotherapy. Um, but thinking about, my friends in engineering, thinking about some people that have no idea of the feelings that they get in their body. Like it's pretty easy to ignore them, right?
Yeah.
You have a cranky knee one day. Who cares? Like, let's go to our badminton game tonight. Let's go to our soccer practice or whatever. Like, I'm not gonna let that hold me down. This is the one time I have to do exercise this week, right?
Yeah.
So it's tricky. It's tricky. It's not, and I think going back to like our value-based discussion, this is where we provide our value as physios. Like, we have the knowledge and know-how to steer people into the right direction, right?
Yeah, totally. And as we're talking about the multiple variables that play into PFP, I think it's just worth framing it with clients in terms of probabilities. Like I really like this model where, because we never know what needs to change, all we can try to do is maximize the probability of success. So we're never placing a bet that we know is going to come good, right? Like we're looking at all these factors, right? Sleep, stress, movement retraining, kinematics, strength, macro, training load. And then we're going to kind of, I think what we need to do is weight them, right? So we need to place a bet on which are the most important places to intervene. Mm-hmm. And the reason you have to do that, and the reason why comprehensive capacity, just addressing everything, doesn't work, is because of opportunity cost. Like if you're doing one thing, you're not doing something else. And we don't have infinite time and resources, nor does the client at home. So you do need to decide what's most important. And this is where, even though we have these prospective studies showing us that X, Y, and Z are important for PFP, we need to find a way of making our rehab kind of bespoke to the client, and narrowing it down and saying, I think that our time is best used doing this or this. Right, and so that's where it's tough, but that's where it's fun, right? Like that's why our job is rewarding and challenging, because no two PFP patients are the same, even though all research ever tries to do is homogenize things.
Yeah, and I think like as we gain more expertise within this field, 1 year down, we're experts now, not even close. But the way that I like to think about it is value-based care, right? So it's crazy to think, but our little job as physiotherapists, we can have a big impact on people's lives, right? And if we're not providing the best care for a certain diagnosis, and if we're not reading up on some of the best practices around a field, we might be that aspect that leads that patient down into a life of inactivity, right? Like someone could be the most active individual, develop this PFP, have a whole host of stress going on in their life. They lose that love for activity, and all those longer term metabolic health, cardiovascular health aspects create a bigger burden on the healthcare system as a whole. So it is kind of crazy to think about how we fit into a bigger picture of the healthcare system. So thinking about this comprehensive capacity idea, we could get people out of pain, but we could also change their minds. We could provide them with resources to live a healthy, happy life, and drive longevity in the population.
Yeah, and I mean, we spoke a lot about that on our last podcast, where it's not just, is my intervention effective for this condition, but what are the secondary benefits, or what are the side effects? That's, I guess, another variable that plays into your decision around what intervention you're going to choose. And that's why I'm choosing exercise for PFP as the cornerstone of the foundation, because even if maybe their PFP doesn't fully resolve, I can prevent kinesiophobia and fear avoidance and inactivity and improve their metabolic health.
And management strategies.
Yeah.
Down the line, right?
Totally. So, I think that's a really important point. Yeah. So I thought maybe from here I would discuss like the only original thought I had around PFP. Because all we're doing really is parroting the thoughts of other smart people here.
Of course.
But,
podcasts teach you a lot.
They do, yeah. Podcasts and PubMed.
Yeah.
What the way that I have kind of been framing how to pick what interventions we use for clients is through like a Venn diagram, where if you can imagine, one circle shows what the research says, one circle shows what you see with your eyes when you assess the client, and then a third circle that intersects shows biological plausibility. Those three factors kind of mediate what I'm going to do. So here's the thing, right? I want my intervention to be justifiable. And so I'd love for there to be research that backs it up, because everybody's, bangs on about being evidence-based. It's in everybody's Instagram bio.
Oh, you better cite those research articles in your Instagram post.
I need that PMID, man, in the comments. Anyways, so here's but what's interesting is that we don't have prospective data showing us on every potential biologically plausible avenue for treatment. So we've got prospective data on, hip strength, whatever. We don't even have it for activity modification and loading.
And this is the tricky part about patellofemoral pain. As we are seeing, the most recent clinical practice guideline came out in 2019.
Yeah.
You look at that guideline, a lot of good information in there, but it's still murky.
It's super murky. And so here's the thing. I think our interventions need to have two of the circles overlapping. So if the client, one of the things I often address or assess is calf strength. I find with people that run, or just general population who get into running, they're super weak in their calves. Like, put them on a decline calf raise with proper form, where they're ascending vertically in an elevator as opposed to going up in the escalator, and they do like 5 reps to fatigue.
They're burnt out.
And so that, to me, even though we don't have prospective data showing that decreased calf strength predicts patellofemoral pain, that's really biologically plausible as a potential mechanism for developing knee pain.
Yeah.
And so that in that scenario, we have an overlap between biological plausibility and what the client demonstrates in the assessment. Conversely, if we just had what we were looking in the client assessment, they have like weak shoulders, that has no biological plausibility, really, as a consequence, as a predictor of knee pain.
Mm-hmm.
So that's not going to be something that I address.
Depends on you ask, but
it depends on shout out NKT.
Yeah.
Anyways, so that's kind of how I think about orienting my interventions, and maybe this is a good spot to talk about how we actually assess people. I've been really fortunate to practice with a dynamometer from literally my first week in practice. We use an inline dynamometer that's called the Tindek Progressor, and
it's a rock climbing tool, right?
It's a rock climbing tool, yeah. Those Norwegian rock climbers. Shout out. But it's been applied in a rehab setting really widely now, and the brilliant thing about it is that you can quantify where they're at in terms of their hips and their knees. So, I was thinking about a client that I had a couple weeks ago where the pain that was arising was most disabling with going downstairs. And I got him on the dynamometer, and we looked at his quad strength. And on the affected side, it was 100 pounds peak force. And on the unaffected side, it was 130. And I'm like, that's a significant difference. That's glaring me in the face.
Yeah.
Tested hips, and they were about 25 both sides. Pretty reasonable, solid hip strength. So, I'm probably going to bias mine. I'm definitely going to train quads.
Yeah.
Do you know what I mean?
Yeah, for sure.
No, I wouldn't have needed the dynamometry research or the dyno testing for me to train. I probably would have trained quads anyways. Yeah. But it's a beautiful tool for buy-in, and it gives us something to work towards in the short and medium term.
Yeah, it's really cool to see a patient's face when they see those numbers, right? They know that there's work to be done, right?
Yeah, 100%. And it's hard, right? Hard to do that with an MMT. Oh, you're up to 4
score,
plus out of 5.
Yeah, I never understood that, and it's interesting that in physio school we don't discuss these more objective measures because we're big on objective testing, but you think like this is one of the most objective tests that we have, right?
Yeah.
Measuring someone's strength with numbers.
And the tin there's like $200.
Yeah, it's
so
very
cheap.
valuable. Yeah, and if you're thinking about patient buy-in, right, like that'll pay itself off. For those patients that, okay, I could see that there needs to be some strength done. Let's buy into an exercise program.
100%. Yeah. A patient comes to mind. I was thinking about like patients that I've had success versus failure with PFP. And there was one patient who had really chronic knee pain, big reliance on bracing, pain running, walking, going up the stairs. And we tested hips and quads. And her quad strength was like equal to her hip strength. It was like 21 pounds.
Wow.
And she was in her mid-40s. And I was like, that's weak.
Yeah.
Do you know what I mean? And so we worked for 3 months on just progressions that we'll talk about. We'll go into that in a second. And when I retested her quads, it was like doubled. It was like 50 pounds.
Mm-hmm.
Hip abductors were roughly the same. And so, like, I know there's a lot of clinicians that really bias the hip. And I think for good reason. Like, I think if you don't have if a patient can't tolerate quad strengthening, start at the hip. But I've seen good results for people, like just trying to find a good entry point to work on quad strength.
Yeah, totally.
You know?
And maybe for our listeners, do you have any numbers that you like to keep in mind when you're doing dynamometry?
I mean, I'm always looking at the interesting thing is that you always ask yourself, do we have good norms? Not really.
Yeah.
The only place we have good norms is ACL rehab. But even there, like they use like a limb symmetry index where like you want it to be at least 90%, the affected side, versus the unaffected side. But what I often see in these populations is that they're weak on both sides. Do you know what I mean?
Yeah.
However, like in the patient I mentioned earlier, there was a big discrepancy side to side. So you have a baseline with their unaffected side, and I think that's pretty much the most pragmatic way of using it. I don't think you can run yourself in circles looking for normative data. Yeah,
and I think that also feeds into the point that you need to measure more than just the quads.
Yeah.
Like you need to look at the hips, right? You can, and it's like outside of the dynamometry, right? Like the calf raise tests, right?
Yes.
Like how many calf raises can you do, right? Like get a sense of the overall function of the lower extremity between sides. Spend some time looking at that, right? Because if you're super lost on that first day with that patient, and there's a lot that you think that can be worked on, those values provide a good starting point, right? When in doubt, you can just work on the things that you that seem weak.
Yeah, and it gives you some grounding. It gives you a plan.
Yep.
There's nothing worse than going back to your chart and just having like continue strengthening quads with no objective goal in mind.
Yeah.
It's sweet. Like when you have a patient that you've it's really just you've been thoughtful enough to, and you've had the time, maybe it's partly just like a resource thing.
Yeah.
But like you've really set goals that are thoughtful. Like they're not just, strengthen quads, strengthen hips, 2 times a week for the next 6 weeks. It's like, okay, like where do I want to be in 4 weeks? What's the long-term plan here? And I think that's probably helps get good results with people is really taking the time to think what's important here, what needs to change.
And shouts out to the independent practice application that we just completed. College would love the objective results, right?
Yeah.
You're tracking change over time. Helps you, it helps your charting, makes you look like a good physio.
Yeah, 100%, man. Is there anything else that you want to chat about in terms of assessment? Because I think when I just think practically, what do I do with a patient? You need to get a baseline of point A. Like, where are they in all these different factors?
Mm-hmm.
What's their tolerance to deep knee flexion? Like, maybe I'll ask you specifically, diving into the details, how would you assess irritability? Like, do you step down? Like, where do you go to look at, deep loaded knee flexion?
I would say if you have the chance to see the patient walking into the clinic, then that's going to be quite valuable. Or even their ability to get out of the chair, that can tell you a lot. Typically, I'm more of like start my exam with a subjective, and you might get a lot of the grit there,
Mm-hmm.
and you might get a sense of, what's the last like 3 months looked like for you, right? Is this a recent flare up? Is this something that you've been living with for 2 years? Am I the fifth physio that you've seen for this, right? That can really help me understand where we want to be. And I think working at Amana has been very fascinating because we have this treatment room that we start our assessments in, but we also have this beautiful gym with access to a bunch of equipment with. And I always try not to forget, do the basics in the room. If that patient is on the lower end of the continuum, just doing a resisted straight leg raise, for example, or looking at quad extension and sitting can tell you a lot, right? Even AROM quad extension, like those basics, right? But if we're thinking about more of an athletic population, I would just try to frame it in the first 4 things that we mentioned at the beginning. So we're thinking stair ascent, stair descent, and any sort of like deep knee flexion. Running can be like a little bit tricky, especially on that first day, but it always depends on like where that patient's coming in with. If you look at, their ability, like closed chain quad function, it can tell you a lot.
Mm-hmm.
Yeah.
Yeah, no, I totally agree. And I agree with you. I think probably 90% of the diagnosis is in the subjective.
Mm-hmm.
But you're kind of confirming.
Which kind of like going back to what we were talking about with how to diagnose it, because a lot of it can be seen in the subjective, don't get lazy and not rule out the tendinopathies, the loose bodies, those weird ones, you know what I mean?
Even like a lumbar radicular pain presentation.
Totally, yeah.
Sometimes if somebody has an athletic history, you just jump right to mechanical knee pain, but do your straight leg raise, do your slump test, do your lumbar range of motion. Does that bring on the pain?
Mm-hmm.
And if it's kind of that weird diffuse pain, sometimes you can get that. You can even get articular hip joint pain that refers to the knee.
Yeah.
So this is where it's worth just being really thorough, and maybe just as a broader point for new grads and people that are just starting out, it's worth being very, very slow and comprehensive in your assessment, even if maybe it takes a bit longer and you don't get any treatment in my opinion. I know a lot of people are really value getting some treatment in on day one, whatever that looks like, but I'm a big fan of just knowing what I'm dealing with on day one. Rule out lumbar spine for any lower quadrant issue, right? Have a quick look at their hips. Oh, does that bring on? I had a patient with knee pain where like hip internal rotation, like scour test, was the only thing that brought it on. And I was like, it's a hip problem. Yeah,
and you're not going to see those every week, right? Like those are going to be the ones that like slip through, right? Historically, right? So you want to make sure that you're the person that finds that, right? Try not to waste people's time treating the wrong thing.
Yeah.
Right? And constant reassessment is huge in this population.
And to screen the lumbar spine and the hips takes like 5 minutes.
Totally. Yeah.
Bend down, bend back, side bend, SLR, whatever it is.
Yeah.
Look at the hip, done. Okay, onto the knee.
Onto the knee,
right?
exactly.
And it gives you that peace of mind that you didn't miss one of those kind of zebras, right?
Yeah. They come through sometimes, right?
They do, yeah.
But if we're thinking about really specifics, maybe geared towards a new grad, functional assessment. So dynamometry, we're looking at sitting quad extension, and that kind of looks like a rim. Prone glute extension is a good one. Again, looks like a rim. Sideline abduction and adduction. So the adduction is a little bit weird. It can be a little bit weird to set up. Do you want to just mention how we do that?
Yeah, so we just have a chain that we hook around the bottom of the plinth, and then we have carabinas which attach to the inline dynamometer. So if you just imagine like a crane scale, that's essentially what an inline dynamometer is, as opposed to a handheld where you're physically pressing something against their lower leg as they lift up, and you have to match or break their pressure. So with an inline, you got to hook it up to some stable surface, and they pull against an immovable object, and then it measures the amount of force that it can output. That goes into my phone. We have a Bluetooth connected app, and that shows exactly, it can show you the peak force, the endurance, as well as the rate of force development, which I do less of.
There's some good metrics, and even the ability for that person to maintain force over time is a really cool one. Because you can, like, I've seen strong people come in, good numbers on that scale, but the endurance isn't there. And that can become relevant, on those 10K hikes, for example. Like, so if you don't have one of those, again, we're pretty biased to having one of those in the clinical setting. But if you're thinking like classical functional assessment, don't need a lot of equipment for this. I would really recommend anyone who doesn't follow Chris Johnson to give him a follow. He's got a lot of good resources, and just recently he posted a good video on how to assess calf strength. You may be thinking that you're doing it right. I thought I was doing it pretty good, but I found some good tips in there that really get a sense of looking at that single leg calf strength, and that's your objective test, right? So we're getting a sense of between sides. What does it look like? What's the displacement that individual is able to get off of the floor? Does it look like more of a elevator when they get themselves up? Does it look like more of a, like you were mentioning, going up the escalator, right? So just like a little bit of minutia, you guys can check out that resource if that interests you. And then like more of the simple ones, get in on a step, any sort of step, could be small, could be, like I would say right around like mid shin level would probably be a good one. And then forward step up, lateral step up, and then a step down. Those are like the three easy ones. They don't take a lot of time. And if the patient's, doesn't have the best function there, get them to use a wall, get a sense of like how that stability is, even if there is no pain.
Yeah. And I would say in order of irritability, I would probably say forward step up and then lateral step down and then forward step down in terms of just increasing the tibial angle. The shin angle dictates a lot of the compressive like stress on the PFJ.
Yep.
So, and then, another constraint that's nice to use with somebody who isn't very irritable and you have to really, you're trying to stress that joint to reproduce symptoms, which happens sometimes, is if you get somebody against the wall and you have a slant board or some way to elevate the heel, and you get them to do a squat in that position, that just ensures that they maintain a vertical torso. And we know that if we're to move somebody from the hinge to a squat into the continuum, we want vertical torso, or as parallel to the shin angle as we can. Whereas if the trunk folds forward, they're just compensating using their hip and their posterior chain.
A good way that I like to remember it is like knee over toe, right? So the deeper that knee goes into flexion, and if you start to see that knee approaching that toe angle, that's typically going to be a little bit more compressive on the knee, and it's not bad. It's just stress, and stress is going to be applied along the continuum, right? So the reason why we start with hip strengthening in a lot of these patients, and a lot of people focus on hip strengthening in PFP, is that if someone with a very irritable joint can't tolerate a lot of knee flexion, then it makes sense to be doing something that involves more of the hip. And that's why wall sits, Spanish squats, goblet squats, even in some individuals, they work because we're shifting that bias onto more of like a hip strategy when we are in that squatting pattern. Yeah.
Like I would doing a straight up hip hinge with somebody can be a nice strategy.
Straight knee, right?
To maintain. Yeah. So if you just look at the shin angle, that tells you everything. Like if you watch somebody deadlift, the angle of the tibia doesn't really change in terms of like horizontal translation. Whereas if you look at a squat, you're gonna have that shin angle going forward, the trunk angle staying vertical. Whereas with the hinge, it just stays where it is. So that's gonna put less stress on the patellofemoral joint. And so if I can get somebody doing a single leg RDL, and that's typically gonna feel fine our RDL, for people who don't know, Romanian deadlift. So that's gonna load up the hip abductors a lot, but not load up the patellofemoral joint. And that can be a helpful interim strategy while somebody's very irritable to maintain their function without pissing off the joint.
And this might be an eye roll for some of the strength gurus out there, but I think it's important to talk about because it's these details that can make or break the patient's exercise program, and that will determine their follow through, right? So kind of go into what we talked about right at the beginning of the podcast, that patient that's coming in once a week and doing an exercise program. If you're not really giving them these details from day one, it makes it hard to manage, right? A squat isn't a squat, right? There's so many variations to movement that it can make it really tricky.
And, the other thing that I would mention is that I've seen a lot of people who maybe I start off with or have been told that it's not okay for your knees to go over their toes. And that may have been a well-meaning coach shifting stress from the knee to the hip when they were irritable. But they didn't frame that with the notion that once it feels okay to put your knee over your toe, it's actually probably beneficial for you to do so in order to prepare that joint for the demands of that activity. So I always try to just give a quick caveat when I'm getting somebody to only do hip stuff, or when I'm coaching a really vertical shin angle, that this is a temporary strategy to offload the knee while it's sensitive. Once it feels a little bit less sensitive, then we want to push back into that forward shin angle in order to kind of get some adaptation there. And this is the same as like a lumbar flexion hip hinge idea, right? It's symptom modification procedure is temporary, and you just got to make sure the client understands that knees over toes isn't like the best position or the worst position.
It's just stress, right?
Just stress.
It's just and you can tolerate that stress better, depending on your activity demands, depending on your day, going back to those big pillars, right? And I think if you ever hear a physio or like an Instagram guru mentioning that there's one bad position, just think a little bit deeper on that, right? That the body's complex, right? We can handle a lot without having issues, right? So there's no point in driving these fear-based approaches that you can never run again, for example. You can never squat again. It's like, what are we really telling our patients if that is the idea? Yeah,
and I think physios, like and strength coaches, we talk out of both sides of our mouth when it comes to stress. We're like, yes, we got to stress your muscle so it adapts, and we like this exercise is good because we're promoting adaptation. But then in the same breath, they'll say, we're going to avoid this exercise because it's like somehow harmful on the knee in the absence of pain. But what we've seen in the literature is very clearly people who train their joints have a lower incidence of arthritis in those joints later in life. Like the data on runners having much lower incidence of knee osteoarthritis than sedentary people is pretty clear on that. So like
bone stress injuries are a good one as well, right?
100%. Like if you never do any plyometric activities where you're running, hopping, you could say, oh man, that's super stressful for your joints or your bones, and that's going to cause an issue. But if you're not prepared for that, and then you go do a bout of that, that's the issue. So this is where it's not the movement that hurt you, it's your lack of preparation for the movement that hurt you.
Yeah, I love hearing this because I hate to say this, but like when I was in like grade 8, grade 7, I totally had a parkour YouTube channel. I was really into gymnastics, jumping off of stuff, and like my dad would get so pissed. I'm ruining my joints, I'm ruining this, right? But it's nice to hear it, full picture, 15 years later or whatever.
Yeah. So important question: is that YouTube channel still live?
No, I got rid of it. I'm sorry, guys.
Oh, brutal. Yeah. But you're right. It's fascinating when you look at those really high load, like on one end of the continuum. There's a right or wrong way to jump off a roof.
Yeah,
to
totally.
disperse forces, right?
Totally.
But I think we're in a bit of the gray area when we come to like shoving your knee over your toes in a split squat. Like it's not going to break people down as rapidly as jumping from 10 meters off of a garage.
Totally. And that is when biomechanics matters a little bit more.
High load activities, right?
Yeah.
I'm definitely biased towards movement preparation over avoidance, but. So anyways, that was a bit of a digression. Let's go into specific exercises and maybe ways to train the quads without irritating the joint, because I find I've had better success building confidence with people with PFP when I don't just avoid the quads completely. Like I feel like I've never found anybody that I can't do something for the quads with.
Yeah.
Whether it's low level or whatever, like, what are some variations that you go to when somebody's very irritable to just give them a stimulus to maintain their quads function, as opposed to completely ignoring it and going just up to the hip?
All right, so it's not going to work in every single person, but the way that I like to think about it is typically closed chain greater than 90 degrees, right? Like pushing into those deep knee flexion moments are going to be a little bit more aggressive on the kneecap. So that can help guide some of the closed chain variations. Whereas for your open kinetic chain, going up into those terminal knee extension moments might be a little bit more aggressive on the kneecap, right? So if you can kind of think about those two factors, again, might not work for everybody, but that can be a nice cornerstone, right? So for the really low level people, open kinetic chain quad extension is a really, really easy way to show people that it's okay to get their knee moving, right? Maybe just keep it to 45 degrees though. And if you're lucky enough to have some sort of leg extension machine in your facility, then, as long as it doesn't hurt, load them up as much as you can in that position, right? Like a really beautiful way of thinking of it that Rich Willie kind of mentioned is we're always riding the fine line of causing a flare up with these patients and avoiding going backwards in a way, like reducing the amount of capacity in their system, right? So, like as we talk about some of these specifics, be aware that you might cause a flare up, but that's okay. It's part of the process, and we need to show these people that loading up the quads is like you're gonna have to do that at some point in your life, and if you see that, okay, I did a little bit too much, and for the next day or so I can just manage the way that I'm treating my exercises, then I can deal with these flare-ups on my own, right? And we build a more robust kind of person. And then to think about like the basics after, like obviously like the hip strengthening is quite important, but I like to think of like wall sits. Like I think that's the one that we always see in physio school when we're dealing with this population, and it kind of goes back to what we were talking about with the shin angle. So starting in some sort of isometric variation is a good idea if you're just starting out the closed chain.
Right. So like a 45 or 60 degree angle wall sit, 30 seconds, get those quads burning, but as long as you don't feel symptoms in your PFP, you're golden. And
some people might not even be able to hold that 45, right? They might be able, they might just be at the top depending on the person that you're dealing with, but it's better than, just focusing on the hip, right? Like I think there's, like you said, there's always a window that we can go through when we're strengthening the quads.
My bias too is that if we can get some stimulus to the knee joint, there might be some peripheral induced hypoalgia, like analgesia there.
Yeah.
You know what I mean?
Yeah.
So even if it's not just strengthening the quads, if I can load that joint and get things moving and fluid dynamics and whatever, like maybe that has a pain modulatory effect.
And this is why like calf isometrics, hamstring isometrics aren't out of the picture. Like we should just consider the knee joint as a whole, especially in those early stages when it's like, quite irritable. Like we got to show that individual that it's safe to do exercise.
Totally, man. And if we can tick some of those boxes while their knee joint is maybe just kind of coming down from that initial flare up, that builds confidence. And to me, that also just functionally, like I'm happier with somebody going back to sport if they have strong hamstrings.
Yeah,
like
totally.
Pragmatically, I always assess that as a movement or a muscle group I'm obsessed with is hamstrings. I have so many athletes who I put them in like a single leg bridge, like a long lever with their forefoot on the foam roller.
Yep.
And they just cramp in like 2 seconds.
It's awesome, yeah.
And it's like, okay, well,
there's work to be done, right?
Yeah. And somebody gets that sensation of, whoa, like that is something I suck at. Like, okay, so there's some work to do here. But it's not like I'm making them feel like they're, weak or whatever. It gives them a target to work towards.
Yeah, like you have to make the exercise engaging. If it's too easy, what are we doing?
Yeah, totally. And I mean this, Rich Willie said it best. If you never get a flare up with somebody with PFP, you're probably underloading them.
Yeah.
So I think that's and that's something as a new grad, which is hard to deal with. It's easy to kind of go a bit squirrely when somebody has a flare up and get red in the face and be like, oh, what are we doing here?
Yeah.
But when you have the confidence to say, listen, we need to provide the stimulus to the musculature around the joint.
And this is the reason why those initial discussions are so important, like setting that foundation at the beginning. This isn't going to be easy. You're going to have flare-ups, but we're going to teach you how to manage them. Yeah. And we're going to get you stronger and get you back to your activities, in some way.
Yeah, and it feels analogous to me, the process with like a femoral acetabular impingement, like FAI, not to digress, or go on a tangent, but I enjoy that kind of patient now because I don't put so much pressure on myself to have a quick fix. And I think I'm better than I used to be at setting expectations. And I've had good results with those people. Like, we follow them for like 4 months, 6 months. And
probably don't have the best results with them in the first 7 days though, right?
No, but if I was staking my how I was feeling about it on those first 7 days, then I'd be a basket case when I came back in. But you just, like we said in the beginning, you just set those expectations appropriately, and then you kind of know what checkpoints you need to hit by the end of it. Maybe that's another point to hit on, is in the initial assessment, it really helps somebody when you can tell them, okay, by a couple weeks in, here's where I want to be. By a couple weeks after that, here's where I want to be. Here's where we're looking at down the road here, and have it be like this checkpoint-based thing. So you've taken some objective measurements. You're like, I want your quads to be at this amount of peak force in terms of pounds within 6 weeks. Let's make that happen. And then this is where we're thinking your activity level is going to be within that time frame. Mm-hmm. And then they're not just in this murky water of kind of,
we're getting stronger, right?
Can't go wrong getting strong.
Yeah.
Anyways,
So I think a nice thing to touch on as well, we can always think about our athletes, right? It's sexy. Like, we got our big exercises with them. We got all the fun stuff, all the high level stuff, but think basics, right? So think about that patient that, weekend warrior. They're busy, they're working 10-hour days. Showing them how to manage like a little bit of pain with a quad isometric, a hamstring isometric, and sitting, using a wall, using their desks while they're on a call. Those can be like easy strategies, right? And again, it's kind of like we need to give them as many tools as we can, so that even if they're not doing their exercise program within a week, they're managing their symptoms, right? They're not getting to a point where they're coming in on their next visit with a crazy irritable knee.
Yeah. So maybe this is a good place to mention some of the symptom modification strategies that aren't strengthening, but and where they might fit into rehab.
And definitely goes against our bias.
Well, yeah, because our bias is to just like strengthen people and hope that fixes all the problems. But there's some pretty compelling data on foot orthoses, mm-hmm. As well as taping for short-term pain relief. So so foot, that's not really something that I've personally used in my practice, foot orthoses. But listening to Brad Neal, who's like a world-leading expert on PFP, talk about this, his perspective was that's probably the lowest hanging fruit for any clinician to improve their outcomes with PFP. Is in the short term, does a foot orthosis, doesn't have to be custom, can just be off the shelf, does it make a difference? If so, that's been shown to produce better outcomes than not doing it. Yeah. And if that allows you to do more in the way of active stuff and strengthening, then maybe that's just the window of opportunity.
Totally. And I think with the orthoses as well, like, you don't have to think about living in those things 24/7 and putting them in your slippers, for example. But the way that he framed it is find those activities that they're having issues with, right? So if they're having their kneecap pain when they're playing tennis, right? Maybe we can put those orthoses in their tennis shoes, and then maybe forget about their walking shoes, right? So it's just like make it specific to the event that it occurs. However, there are those people that have the, the cinema sign, for example, and they're having the prolonged knee pain with everything, right? So the way that he framed it is, it's better than nothing, right? It's not going to trump exercise, but it is better than nothing. So let's, start a rehab process with at least something, right? Cause a little bit of change, and then that might be enough to get the ball rolling on some of those trickier patients that are a little bit apprehensive into getting into any sort of exercise approach.
Yeah, and I think it's so important we keep an open mind with respect to some of that stuff, because when we look at the data on heel lifts for Achilles tendinopathy versus eccentric strengthening, there was a trial that came out, I think it was 2019 or 2020, which showed that heel lifts did better.
Yeah.
In terms of pain. And so,
these are easy tools.
They're easy
right?
tools. Yeah. And I think the bias towards strengthening and active interventions is a reaction to physiotherapy being, for many, many years, simply consisting of passive stuff where you're on the table getting pain relief modalities given to you. But it's important not to completely discount things that can help people get out of a bit of suffering and continue their activities. The way that Brad Neal framed it was like Tylenol for a headache. If you have a headache, take some Tylenol, it helps you get to sleep. You wake up in the morning, you don't have a headache, you're not going to take more Tylenol. So maybe if this intervention can help somebody acutely with pain, it's not clear. I don't think we have good data to show that people become dependent on them when their pain goes away. It's a tricky conversation, because I think that can happen, and I've seen that happen.
And it has happened, right? Anecdotally, both of us have had experiences where the patient really starts to rely on those passive modalities, right?
Yeah, I've had cases where, for back pain, for example, I do some active release technique. I can't call it that because Cairo's copyrighted that term. Soft tissue release with active movement on the.
We're gonna have to scratch that.
We're gonna have to edit that out. No, but use some soft tissue, and then you also give them some movement strategies, and they come back. They're like, I need more of that soft tissue. That's what got me better. And then for months they're like, they just want soft tissue, where you're like, I could be spending this time so much better, but because I opened the door to doing that manual technique, now the door is it's glued to the wall.
and again, this is why communication is so important, right? Set your expectations. Don't make them reliant on these things. A really bad way to apply tape is to say that you're changing the structure of their kneecap, right? And gliding it into a certain direction when we know that is not the case.
Yeah, there's a trial out there that showed that doing a lateral glide of the patella actually induced more pain relief than a medial glide, which completely flies in the face of the biomechanical paradigm that the lateralization of the patella and the increased pressure on the lateral pole is what causes pain. So
it seems like within this last year of diving into a little bit more of the detail, some of the stuff that we don't really talk about when we're in physio school is that things are a little bit more simpler than they actually seem to be, right?
Yeah, exactly. Don't make things as simple as they need to be, but no simpler.
Yeah, exactly, right? If you're overthinking about the way that you're going to glide something, and if you're stressing out before you're putting on that tape application, you should probably rethink about your overall narrative around why you're using that modality.
Yeah, that's what we would call majoring in the minors. So, is it worth circling back to exercise variations to train? I have a few more that I'd like to mention. Maybe,
totally.
To train the quads. One thing that I'm privileged to have access to at the clinic where I work is a sled, and if you have something that can mimic that, a reverse sled drag I've found to be really well tolerated by knees that don't like deep flexion, because somebody's basically holding the TRX straps, which are pulling the sled, and they're working within that maybe 30 degrees of flexion, or even 20 if they take really small steps into that terminal extension. And their quads, you can get a crazy stimulus into their quads without irritating the patellofemoral joint. So that's a favorite for me. And man, I surprise people. I'm session 2. We're pulling a sled, and then they get a sweat.
Yeah.
And when you think about the psychological consequences of having this disabling pain, I think that has a myriad of benefits just in terms of confidence and keeping somebody feeling like they're an active person.
Yeah.
And so if I could choose between a sled pull and like a quarter squat, they're both beneficial, but maybe you tailor that intervention based on who's the client in front of you. Are they somebody who really identifies as an exerciser?
Mm-hmm,
If
mm-hmm.
so, like we can give them something that makes them feel strong.
Yeah, definitely. Yeah. Definitely. And again, like thinking about mechanism, it kind of goes into that Spanish squat kind of wall sit like family of like the movement that you're in, like with an upright trunk.
Yeah.
So it tends to work really well in those early situations. And that's why like, exercise progression can make a lot of sense when you have some of those like nice principles right at the start of your program.
Yeah. And then the other point that I would make to new grads and speaking to myself in the past here is to really recognize the importance of making micro progressions. So it doesn't need to be a new exercise every week. It can just be literally increasing the volume by 2 repetitions. Like that can be success. Like if you find, and I think often we overcomplicate things by picking too broad of an array of exercises. Like, okay, you're going to be doing reverse Nordics and split squats and step downs and bilateral squats and sled drags. Whereas you could take 2 of those and then over time progress that in terms of volume, intensity, angle of the shin, all these things which mediate patellofemoral and joint stress. And I think if we manipulate too many of those variables at once, it's hard to track where we're at.
Yeah, and I think overall, it like for your own framework, it's a little bit easier to track change, and for the patient, when they're seeing the continuity between exercises as opposed to throwing them into a new exercise every time that you see them, they can see like, damn, I'm actually changing. Like I'm actually seeing like this is easier than it was a month ago.
Yeah,
right? Like I was not able to step up at this height. And it's really empowering for the individual.
And maybe a patient doesn't have, obviously, often a patient doesn't have the technical knowledge to understand what the difference is in difficulty between, a front foot elevated split squat and a lateral step down. So if you give them those 2 different variations and they do really well on one, how are we kind of making an equivalency there?
Yeah.
And comparing the 2, that might not have the same effect as if you just like crush step downs and they can do more of those, they're like, wow, like I'm making progress, like you said.
Yeah, and then I think going to Rich Willie's point about the passive treatments, like the orthotics and the taping, right? Like some of his beef with those treatments is that it can take time away from the exercise program. And for example, like when we are exercising with these patients, right? But if every single time that you're with this patient, you're switching things up and you have to reteach them how to do 5 new things, you're taking time away from the things that they could be getting better at that you've already showed them, right? Yeah. So just, again, going back to that value-based care.
Totally. Yeah, and this is why, if I'm short on time, I'm probably not teaching somebody a single leg RDL if they're an untrained person.
Yeah.
I'm probably going to do like
any sort of hip hinging on those long days.
Listen, like it can take like 10 minutes to teach. Totally. This is where like from the strength coach perspective, if I have the choice between like a loaded jump and a clean, loaded jump wins 10 out of 10 times because it takes like 2 seconds to teach and gets you all the same benefits as a Olympic lift, which is super technical and hard to teach. And has all these other elements to it, which are irrelevant.
You spend an entire session, right, on one exercise.
Yeah, and you got to ask yourself, like, is this exercise giving me the biomotor qualities I'm trying to develop? What are those biomotor qualities? And is there maybe a trade-off between the skill acquisition required for the exercise and the strength? And this is where, like, an open kinetic chain knee extension, like Rich Willie has said it, a lot of people are kind of on this train of thought now, is the most functional exercise for the quads. Because what are we trying to do? We're trying to force the quads to produce force, right? And so if I put somebody in a squat, the body is really good at shifting stress to the hips in ways that are even some research has shown not detectable, like
Mhm.
observationally. And so we want to if we want to shift stress somewhere, we need to constrain the movement so they have no option but to complete the task
Yeah.
by the means we want to.
Yeah, isolation exercises have value, right? And I think we see it in our gyms. We see those exercises, and then I think even going through physio school is kind of funny. Like I was straying away from those exercises because I wanted to be more functional. I wanted to have bigger movements, sexier looking exercises, look good on the gram,
Yeah.
right? But then there's just like there's value in just training hamstring strength in a prone like knee flexion, right? Like those simple things.
Yeah, like we both recently got a gym membership at a local kind of like not a big box gym, but a gym with machines, and
it's so refreshing.
It's so refreshing because like
Yeah.
When all you have is free weights and barbells and stuff, it's so hard to isolate certain areas. If you just want like a pump of the hamstrings or like the chest,
yeah,
man, I love a prone hamstring curl. Like
yeah.
The issue in a physio setting is that it's not feasible to have all that equipment because it's only reasonable for one exercise. So it probably doesn't make sense just logistically to have all that stuff if because there's going to be like you're not going to be using it all the time, and you don't have unlimited space.
Yeah, and it's probably trickier for those clinics that have been around for 20, 30 years that have been treating more in a passive approach where you're coming in and your physio is your mechanic, right? You're getting your little tune-up. But then I see a couple of like physio clinics that are kind of changing their philosophies and like driving a little bit more activity. And it can be tricky, like when you've set your clinic up in this set way, like how are you supposed to fit in like a leg extension machine, a calf raise machine, right? Like it makes more sense to have this little bit open space. But you see like, places like Pulse in Peterborough, like the movement in Dundas, right? Like these clinics that Omana, right? Like we have this like established gym space. It can make it a little bit easier to, modify as the years go on, just maybe move a little area to assign like a new machine, for example.
Totally. Yeah. And I'd say it's worth it. When we're thinking about something like how to isolate the soleus, like how many runners do you see, right? What's a big foundational principle of strength training with runners? We know the soleus does
damn calves.
The calves, man, the calves are the workhorse. Like they do the most work. So if you're trying to train soleus with like a bent knee standing calf raise, you're gonna be bottlenecked by how much weight you can carry in your hands before your soleus get fatigued. So just like this seated calf raise machine.
Yeah. It is interesting to see like how much better you can feel too. Like when you've gone from this kind of like functional training for so long, and then you've added some bit of like isolation work in your routine.
Mm-hmm. Yeah, 100%. Yeah, it's underrated in my opinion. Okay, what else do you want to cover? Is there anything else in terms of exercises that you think would be worth bringing up? I know it kind of feels like we're diving too much into the weeds when we go through that stuff, but for new grads, I think it can be helpful.
We tried to create this episode to be practical, right? Like we're not the experts, but at least if we can provide some tools and tips and tricks, then it might be useful for someone else. So
yeah, just tell people like this is what we actually do.
Yeah.
This is what we've been doing with clients. We struggle just like everybody else, and no two people with PFP are the same, just like any MSK condition.
Yeah.
But I think you need these kind of big rocks of treatment to fill your bucket first, right?
Yeah.
And
So over the last like week or so, since we've dove into this topic, what would you say your takeaways are, just to kind of like wrap things up?
Yeah, so one of the big takeaways, I think, is that treatment needs to be, that Venn diagram is a big one. We want to pick interventions that are supported by literature, but we want to also weight what we actually see with the client, and then we want to look at biological plausibility. That framework, I think if I get lost and I'm thinking, am I doing something that's worthwhile here? Can I get an overlapping region there with at least two circles? That can be helpful. I think the other thing I've taken away is just that it's really important to have that conversation on day one about prognosis being not so great.
Yeah.
You come out so optimistic as a physio student, And I remember having conversations with clients early on where I set their expectations way too high. And it only leads to issues. If you can over-deliver relative to expectations, that's a lot better than under-delivering. And knowing the stats on prognosis is so critical.
Yeah.
Those are the things in presentations in physio school that you just ignore. Because you're like, that doesn't matter. Like, that's just boring, like, introduction material.
Yeah, totally. Like, get me the special test.
Give me the special test, man. Like, I would, like, let's grind some patellas. Where's Clark at?
Oh my gosh.
Anyways, just those basics, what to expect is so critical. Yeah.
And I hate to do this because I feel like once the BPS kind of model, all the psychological factors, all the social factors, like thinking about pain is more of a complex experience, it's always brushed off right to the end. I feel like we're doing that right here, right now.
Yeah.
But like I would say to anyone treating this condition, and I think just in general, like pain is complex. And if you can address some of those bigger pillars that we were talking about, that might make a difference. That might make a meaningful difference in that person's life that they might think about, 10 years down the line. They might not remember that exercise progression that you gave them, but if you gave them some tips and tricks around recovery, around like load tolerance, around like maybe some sleeping effects, quick little tips and tricks, like you'd be surprised what sticks.
Yeah, I totally agree. And maybe the magic of clinical practice is being able to zoom out when appropriate and zoom in when appropriate.
Yep.
And be a bit myopic on biomechanics for 30 seconds and then zoom out and account for these other really important broad factors which we know impact recovery. So I think that does it for me. If it does it for you.
Yeah, this was fun. Thank you for having me on.
Thank you so much for listening to the Paradox PT podcast. If you have any comments or feedback, we'd love to hear from you. The best way to get in touch with us is on Instagram. Adrian can be found at commoncuriosity.pt, and I can be found at leo.physio. We'd also really appreciate it if you gave us a follow and a like on whatever podcast app you use so you get notified about future episodes as we release them. Once again, thank you so much for listening, and we'll see you next time.